I would like to call our next speaker, Dr. Ramanuj Mukherjee, who will throw light on open venous surgery in the era of endovenous surgery.
A very good afternoon, ladies and gentlemen. I think I'm audible, and believe me, I'll not make you go to sleep to start with. Ladies and gentlemen, I'd like to thank Dr. Krishnendu Mukherjee, Dr. Jayanto Das, Dr. Shubhabrata Banerjee, and the whole team for this kind invitation and an opportunity to be in presence of majority of endovascular surgeons. Now, to start with, welcome to the city of joy for all the dignitaries who are coming to the Kolkata, and I will take around next 10 to 15 minutes maximum. What I will try to speak of is about things which do have an evidence. I'll try not to go beyond evidence. Now, to start with, I am a professor of surgery, and I work in RG Medical College, one among the oldest colleges in the country. And I usually go on training one among the brightest minds, teaching them the art and the philosophy of why is surgery done. Now, when Shubho told me that what should be one of the topics of the talk, well, I told Shubho that I do not know how many of you know about this gentleman called as King Canute. Little bit of mythology things. Well, Indians love mythologies. And this gentleman was an English king, and he felt that at one point of time in his life that he had a control over everything in his life. Even the sea will be hearing to him. So in a tide, what he did was, the rest of the subjects told that, yes sir, you are larger than the god. So he took his chair, and you can see his throne in front of the sea, and commanded the sea that now recede. The sea didn't listen to him, and he got entrenched by the sea, ultimately making him realize that, no, you are not powerful. There is nothing more powerful than time, ladies and gentlemen. And I now feel like a King Canute. In the times of endovascular surgery, which is gradually becoming the standard of care, well, I am still stuck in an era where I still do teach and do practice open vascular surgery. Now, to start with, laparoscopy came in a big way in late 80s, 90s. Laparoscopy started in a big things. And around 1.5 decades back, we used to do a lot of ACTS. With that 5mm scope, I do not know how many of you still do that. And that is the only thing that is somewhat partial, say minimal invasive thing that we did about a varicose vein. But then gradually another revolution came, something called as endovascular. So now again some hard facts. A couple of years back, I was having a debate with Dr. Krishnendu Mukherjee. We both are very avid debaters. He is now off to fight a debate. And what is important is that we are having a fight around that who will win, open or an endovascular. Well, I do not know who won that day. I've forgotten that. But what is very important is that with time, endovascular surgeries have proved that they are marginally better. Now use the word marginally. And they have proved that thinking about patient's compliance, thinking about the way the disease physiology goes by, yes, endovascular is, and as I've said, being like King Canute, I will accept, has become the gold standard of treatment. The only thing that remained, with many colleagues talking about that, is it cost worthy or is it cost effective? For this reason, for those who still are skeptical about what is the price thing issue, as I have said, this article from NEGM, and I hope all people know what is NEGM, showed that if you see about the cost analysis model, definitely laser ablation goes a way up. If you are still stuck in foam sclerotherapy like I am, the effectivity gradually decreases over time. And I am still stuck on that slow, small blue line. I am an open surgeon. Well, our job becomes a little more easier. But that means our endovascular colleagues have a much big advantage than we do. So now my next 8 to 9 minutes will be on, still in this good things about endovascular, what is my job. The answer that I see and that I teach my students is all about 5 C's. Number 1, you deal with complications of a venous disease that will not be very easy for the endovascular guy to treat. Number 2, complex anatomies which will not be very amendable to a endovascular treatment. Number 3, some veins are inherently complexes, and the more the tortuosity, the more will be yours caliber. It will be like driving along a very spiral highway on the mountain. Number 4th is a bitter pill to swallow, competence, which definitely will improve with age. And number 5th, which is a very polite way of saying that, well, we cannot afford this. Now, the last one may look like a bit controversial, but is not probably in a country where you will get the best of the hospital facilities with the most, say, skewed patient is to doctor ratio. But probably one of the important points in the last one, and as my previous speaker has said, is thinking about what we can do to make the therapies Indianized to a version. And I agree with Professor Patel on that point, that, well, if you think about Jugaad is a very stop-gap word, it is not. One of my mentors used to tell me, Ramanuj, think global, act local. The more I age, I get to realize what Sir had told me. And it is indeed, ladies and gentlemen, a very privilege to have one of my mentors, Professor Nidjor, to be as one of the chairpersons of this session in this. Now, what are the complications that my endovascular colleagues will face tough time? And I believe, as I have said, the more the age, the difficulty dies down. Are about ulcers, a 4B or a 4C LDS, and marjoline or an active bleeding. Now, marjolines are something which we general surgeons are usually pushed to handle out, and we usually have a consultation with plastic surgeons. But the important thing I see a lot of people with black hair rather than us having grey, and from a healthy part of the ulcer, that is the edge of the ulcer. You don't go and attack the center. No, that's not the place that you should be. Take something around. I don't know whether it will work or not. Yeah, it works. So it should be around this part, and you should be taking up till the fat. Number 2, after that it bleeds. It does bleed. Then the best thing is that, something that I tell my residents, the 5 P's of hemostasis. Just put a pack. The next P is pressure. The third P is most difficult. Patience. Take 5 minutes by the clock. This is the third P. The rest of the 2 P's are usually not required. The 4th P is a phone. Sometimes that I get a call. And when I come and I cannot control the bleed, I do the last P. I pray. So usually I do not get these situations. But what is important is that these are situations which should make you know how to control a venous ulcer bleed. And believe me, every one of us had our share of patients who will bleed in the ward in 12 o'clock in the night, when you will be getting a call, ki, sir, kuch kijiye sir. Then remember that, just elevate the leg. Complex anatomies are really more complex than you think, and more are they in recurrent varicose vein. And remember that all the imagings that we are teaching, MRI, MR angios and CTs, are really helpless in that. So if you are a beginner with an endovascular, probably it is better time not to do that case and to call on someone senior to do that case, or to better stick on to your old things that you learned in that. Now, talking about, after I've completed the 5 C's, what are the surgeries that are done, or what are the things that I teach my residents? I tell them that, you see guys, there are 3 things that you need to answer out when you get to see a Doppler report. And believe me, when I talk about a Doppler, well, we have crossed a long way. Even books like Bailey and Love say that, well, clinical examinations and handled Dopplers are not exactly very, very useful. So your color Doppler report has to be understood by you if you want to be somewhat of a venous surgeon. So that means there are 3 things. Is the SFJ SPJ competent? Number 2, which of the perforators are incompetent? And knowing that as a surgeon, we have had our bad experiences to know that you have to stand in that ultrasound room while that thing is being done. If you don't, then you have to do the ultrasound yourself. Number 3, what is the status of the branch varicosities? Now, whenever we think about an SFJ ligation, important things to understand are that out of the 6 branches that are there, remember that you should be searching for the 6, not 5 or 4. Next, there is an artery, that red thing, that is called as an external pudendal artery. If you injure that artery, the problem is that it messes up your field. It is better that take a mosquito, blunt one, dissect off that artery. If it is coming too much way, stuck up with that vein, you can ligate it. Don't let it, make a part of the vein. People have said that yes, for beginners it may be. But again, I have not practiced that. I have been taught by my teachers to do a conventional SFJ, and I still do that. Now, to strip or not, well, again, the issues will remain. People will go on with controversies. If it is a cosmetically looking bad, tortuous, anaconda-like vein in the upper part of the thigh, and the patient wants to wear a Bermuda to the next visit to Goa, it is better to take that thing off if you are not doing an endovascular. Next, perforators. Again, the issues about perforators are in those patients who are taking anticoagulants, because we have seen nasty hematomas, post-op bleeds become that popular, where people try to propose something. Well, probably one of the reasons is that when there are many ways to treat a disease, there is no single better way. So maybe one of these came around 10 years ago, did not get that amount of notice that it should have had. And I will consider it, I did around 2 cases, didn't get impressed by that one. Probably because my access to a Doppler is not that great. But what is the philosophy of this operation is that rather than take out the whole system, you exactly attack the points which is going to treat the reflux process. Like say, if you can treat those blocks, those green blocks, at the SFJ and maybe at the mid-thigh perforator, then that is one. One is the short saphenous, 2 is the deep vein, and 3 is the great saphenous. So if you can understand this picture, remember that the first picture, that means before one, is about all the reflux things that are going around. After means that after you have done this, only this targeted ligations at very focused area, which are identified with a handheld Doppler, then you have accomplished what you desire to do. But the recurrence rates will be around 30%, which is not very acceptable. Foams will still continue to be our workhorse, which is still replicated, is a resident proof thing. You can teach your residents. But the only point of this is that residents get impatient. They usually allow the foam sometimes get mixed up with the deep veins, which is not a good one. Final ones before I end now is that which one to do first, open surgeons or endovascular one? Well, I think this one is still in a bit of debate. I do not know whether this answer has been. So in this August gathering, maybe you guys will be telling in which one is the better one, Ramanuj. Well, the only thing that I know of is a study around 8 years old called as an Eshkar study. Maybe there is something more robust than this Eshkar, which is that it doesn't matter really whether which one do you operate. But yes, if there is a venous ulcer, it is good that you have a surgery and a compression rather than only a compression. Compression will heal, surgery will prevent that ulcer. First ones, I usually teach bright young minds, and one of the bad things about that is that I get to answer a lot of tough questions. So all of them asked me that, who told you that this is good? And I sometimes get one of my residents who keeps me asking that one. Well, I tell them that, well, it is good that little amount of knowledge that we do have is something called as an evidence. And this evidence comes from something called meta-analysis and systematic reviews. And there is this free site called as Cochrane, which you are required to look up. And as I've said, if you say about RFA versus ligations, well, there is no clear difference in the technical success. So that means, well, we are not talking superiority trials. We are talking they are non-inferior. That means we are now in an era, 2023. Maybe 2032 will be having that, yes, Cochrane is going to say there is a clear difference. And if you think about the next one, that about the other ones, that ultrasound guided foam sclerotherapy versus land ligations. Again, maybe the ligation one is better than the ultrasound guided foam sclerotherapy. Again, as I've said, we don't have evidence yet. Now, which is the best procedure for treating varicose veins in the leg? A very blunt question. The answer to this is very simple. We are still uncertain about which treatments are the best. So, ladies and gentlemen, I think that what is important is what you are trying to do must have a logic. Your logic will determine your outcome. At the end of the day, your patient needs to be safe, and you need to taper your treatment to what is the job that you are trying to do. So if you are trying to do an endovascular, probably it is more important the safety issues rather than why are you doing it or for the cosmetic issues. And then your open and the endovascular will probably be a complement rather than a supplement. With this, thank you very much. I exceeded by 1 minute. That's very sad. And with this, thank you, and whatever little questions that I will have, thank you.
Thank you, Dr. Mukherjee.
Thank you.
That was really an engrossing session. The 5 P's of hemostasis, time, logic, it really was a crucial factor.